my friend and colleague of long-standing Roland Lamb. So I have prepared remarks here, but we came up together. This guy ran, when I first met you, you were running, let us say, a challenged treatment program in West Philadelphia.
Yeah.
And so challenged that they were willing to have the University of Pennsylvania come in and do a science project there. And Roland ran it and made very few resources turn into something that was really special for the community. And unlike almost any other person, was very interested in using the results from that initial study to actually improve treatment and make care better. So this guy has been a collaborator and friend since he was good looking, and that's a long time ago.
It's a very long time ago. In fact, that's another era.
And now Roland, with his colleague Dr. Arthur Evans, is responsible for all community behavioral health, and the Office of Substance Abuse Services, probably getting the
Office of Addiction Services.
Yeah, yeah.
Oh, yes.
Like I said.
Yeah.
And be very proud, because under Arthur and under Roland, Philadelphia was, I do believe, the first city. I guess Connecticut was perhaps the first state, but Philadelphia is the first city to really move towards translating that old system into recovery-oriented systems of care. And that has been an effort that's been ongoing here for the past, 6, 7 years now,
Yeah.
I guess. And it's thanks to Roland and Arthur. So I should first say, before Roland begins his talk, this is all thanks to a grant gotten for us by Abigail Woodworth, an unrestricted grant to bring speakers in that we think a lot of, who have taken research and turned it into something good for people, which is really what we're trying to do as well. So without further ado, can't wait to hear Roland Lamb.
Morning. Start there. I am especially privileged and proud to be here. I am a TRI groupie. It goes back to when you guys were on the other side of Market Street. And Tom and I have known each other for a long enough time that I can say that I am a Tom McClellan groupie. I really have enjoyed our collaboration and our working together. And I actually prepared this presentation, and as usual, I'm long-winded, so my presentations are long-winded. So if you find me going through this pretty quickly, it's to get to the point or the part of this presentation that I actually have designed to intrigue you or even say seduce you. Because there is a natural synergy between TRI and addiction services. Let's not kid each other. We are also, I'm also very clear about the fact that we need to align, coordinate, and integrate at every opportunity. In fact, my staff is tired of hearing me say that for the last 8 or so years, and would like to have me say something else, but I had to keep on saying it because we need to find every opportunity to do that. So I welcome you to the Office of Addiction Services, and this is pretty much a way for me to say to you, we are involved in a lot of things these days. Whether it's throughout the city of Philadelphia, we oversee over 57 programs that are providers that are operating about 117 facilities that are licensed to provide drug and alcohol. We also have invested heavily into developing non-licensed community-based services, and then we'll talk about that as well. But what's really important is that we need to begin to figure out how we can improve our approaches to improve outcomes. And outcomes, I think, is a very important piece here, because we are challenged today with a population and populations that are multi-diagnosed and they are diverse. We also need to begin to think about what our options are, what the solutions are, for what we have to do. So we'll kind of cover all these topics and, as we go through this today. The Office of Addiction Services pretty much oversees all the activities I said earlier regarding drug and alcohol throughout Philadelphia. The picture you see on the side here is really the leadership of Philadelphia, and that's all the people who are in recovery in this city. I think with the first investment that we make is in the people that are in recovery in Philadelphia. And the fact is that it's those people that begin to drive it. I would dare say to you that our transformation, and by the way, this is the 10th year of our transformation. And that 10th year allows us to say we need to take a look at what we have been able to do. And one of the things that pops out to me is that right now we have a number of people who are in recovery who are ahead of the curve. They are ahead of where we are. They are doing some things that are very, interesting and challenging. The Office of Addiction Services is pretty much, and this is an organizational chart from hell, and 6 core areas. We come under the Department of Behavioral Health, Intellectual Disabilities. Arthur Evans is my boss. Dr. Herford oversees the behavioral health side, which includes the Office of Addiction Services and the Office of Mental Health. And under the Office of Addiction Services, you see 7 core areas. 2 of the 7 are, I guess you could say, the primary cores. What I want to point out to you all, and I guess this is these boxes down here, the idea is that we want to make sure that all these services are seen throughout all the core functions. So that means as you see service management, Niatex, the ATR, the Affordable Health Care Act, we need to make sure that all these things are happening across all of these systems, and that all these systems are in turn reinforcing all of these initiatives. The Single County Authority, which is the first core, is where we do our contracts. We are the city of Philadelphia, foremost, and we have to do contracts and whatnot. But the Single County Authority has also been the lead as far as the recovery transformation is concerned. When you take a look at a lot of things that we do to support the recovery walk, and by the way, I want to challenge TRI to bring researchers to the recovery walk this year. The one thing that we do need is to expand the community, and we had 20,000 last year. I'm going for 25,000 this year. These are some of the things that we do under the SCA. We look at grants, allocations, policy, contracts, providers, and justice. And in justice, we have a serious investment in terms of funding at least 8 initiatives throughout the municipal and common pleas courts. On the behavioral health side, the special initiative side, we have an opportunity, and we actually reorganized the Single County Authority to be the conveyor of grants, but the special initiatives allows us to take those grants and put them under the umbrella of recovery. So we just don't use one pot of money for one thing. We're using multiple pots of money to fuel the idea of recovery in our system. So, and as you'll see, BHSI, which is the managed care for those who are underinsured or uninsured in Philadelphia. Drug and alcohol case management, I'm particularly proud of this. After several bloodlettings, we were able to get drug and alcohol case management included as a supplemental in health choices, which means that we know CBH is now paying for drug and alcohol case management. And that's very significant when you consider the fact that who needs case management more than the people that we're seeing. We have housing, whether people know this or not, we spend a great deal of resources in terms of providing recovery housing. That's been put in jeopardy over the last 2 years because of the 2 things. One, the GA cuts that came out of Harrisburg, which took adults off of their general assistance, and then the fact that we have a state Department of Drug and Alcohol programs that has said to us, you can't use any of our money to directly fund recovery housing for more than 90 days because they haven't got it in their heads that somehow 90 days is a magical number. And so we're pushing back, and in fact, I will give you all a secret. The term directly funding recovery housing has been used by me, and I will take credit for this because if anybody gets in trouble, it'll be me, for now saying, okay, treatment providers, I'm going to come to you and say to you, I'm going to pay you for treatment, recovery enhanced treatment. And recovery enhanced treatments, should include you being able to bring recovery housing to the table. So I'm paying you for treatment. I'm not paying for recovery housing. I am paying for treatment, which is right now sneaking by. We have something called, core services. Believe it or not, we are actually taking services like domestic violence, life skills, literacy, education, training, putting it in recovery houses, taking it to programs, putting it right into the community. We're also providing, we're overseeing the treatment of both adolescent, adults, children for drug and alcohol across the city. But when it comes to kids, it's really important that we remember, we're not talking about a drug and alcohol. When kids come to the table, they are kids that come to the table, and they bring a whole host of issues that we have to be cognizant of. I would love to have a kids or an adolescent program that never mentioned the term drug and alcohol, but was able to provide the services needed for a young person who has drug and alcohol issues. In fact, we need to do more of that as far as families are concerned. And then we have data management, and this is the area that I want to, hopefully intrigue you guys with as we move, on. And that is the community epidemiology work group work that we do, the data warehouse that we have access to, the GIPRA stuff that we're doing with the federal government, the clinical claims, the Southeastern Pennsylvania Household Survey, and the Philadelphia Profile. We have a number of community-based partnerships, the Prevention Partnership, which allows us to interact with 3 grassroots organizations in the community, Prevention Point, which is our harm reduction initiative, the Syringe Exchange, the One Day at a Time, which is a grassroots recovery organization, community anti-drug coalitions. We actually contracted with CADCA to work with Philadelphia's coalitions. Believe it or not, there are 5,000 drug-free communities, funded drug-free communities across this country. Guess how many Philadelphia has? Right now, 0. They had 1 before, and they just lost their allocation. So we have put together 4 coalitions. We brought in CADCA to train those coalitions, to give them the background they needed in order to apply for the grants, and so they've all applied for the grants, and keep your fingers crossed. Hopefully, we will get at least 2 of those grants. We also support the Pennsylvania Association of Recovery Residences. We have to bring standards to recovery houses. As long as recovery houses operate without standards, you're going to have too big an extreme. Programs that run well, and those are the 17 houses that we have under contract, and then those that are not really recovery houses. They are flop houses. And so we have to be able to create an association that's going to give us some standards across the board. The PA Association of Recovery Residences is now up in Harrisburg meeting with, used to be the Philadelphia Association of Recovery Residences, is now PA, because they've now been working with Harrisburg on legislation for recovery houses. We have new pathways for women. Very good program. The director just got plucked up by some folks in Baltimore to go down there, but the thing about it is that this is not a treatment program, but it's a pre-engagement and post-engagement program. It is where women can go who have been, traumatized in their addiction and, be engaged without having to be in a treatment program. We also have PROACT, and that's our most prolific partnership with the Recovery Community Center. And if you have the opportunity, go down to 17th and Lehigh and check it out. I think it's a program for people in recovery, run by people in recovery. One of our other partnerships in the community has been the Mural Arts Program, and I just wanted to share with you, this is the recovery mural that's on 4th Street, and it actually helped us to bring a community and a methadone program together. Over 1,000 people from the community, the program constituents, and the program staff worked on this mural and the surrounding poetry that goes around the wall. We also have collaborations and partnerships. We've collaborated with the PA Association of Recovery Residents, I said earlier, American Association for Opioid Dependence. We hosted the conference, and by the way, just so you know, this conference last year, was the most successful ATOD conference in terms of attendance, in terms of workshop evaluation, in terms of overall satisfaction. We kicked it in Philadelphia. You guys should be very, very proud. We have the DDAP. We are partnering around with Secretary Tennis in terms of the Pennsylvania Overdose Rapid Response Task Force. We have the regular, every 2 months, we meet with all the medication-assisted treatment providers, the DEA, and the state around, looking at ways that we can improve service delivery, and we can bring in the quote-unquote regulators so that they can own part of this. We also have quarterly prevention provider meetings. We're meeting with everybody who's doing prevention in the city of Philadelphia. We're very much concerned that our Philadelphia school system did not participate in the Pennsylvania youth survey, which would have allowed us to have much more qualitative data around kids. Only 21, I think, charter schools are participating. None of our public schools are. So we're now doing a back door where anybody that's in the schools that's in our system, we're bringing in, and we're actually gathering information through them. We also have, monthly meetings with the justice system in terms of the DA's office, the public defenders, the adult probation and parole. Of those recovery houses that I talked to you about, 70% are used for criminal justice reentry. Last but not least, we participated, and we were actually the instigators of a collaboration that allowed us to bring together community care out west, IRETA, SAMHSA, the University of Pittsburgh Medical Center, the Department of Drug and Alcohol Programs, and people in recovery and programs to create the management of benzodiazepines and medication-assisted treatment. This is out now. You can go to the IRETA website. You can download it. I would suggest that you do. These are guidelines, and I think some very good information that providers can use, even though we still have not gotten beyond the risk management issues that come up. We have 4 domains of practice. Many of you may have heard of this. The practice guidelines were produced 3 years ago and sent out to the community, primarily looking at 4 particular areas that we're supporting: assertive outreach and initial engagement, screening, assessment, service, planning, and delivery, continuing support and early reintervention, and community connections and mobilization. These are the priorities that we've identified. These are the system goals, and I'm not going to go through those, but these are the goals that we, as the department, have identified. But the Office of Addiction Services has focused in on 6 essential transformation points. First of all, we look at vision and values. If we're not clear about our vision and values, then who else is going to be clear about our vision and values? And we're actually about influencing and infecting wherever we go now regarding vision and values. We have high-performing collaborations and partnerships. Think about that, guys. We're invested in community integration, focused interventions, integrated healthcare, and wherever we go, finding healthcare champions, or in this case, recovery champions. One of the things, initiatives that you saw earlier in those boxes, is Niatex, which used to be the Network for the Improvement of Addiction Treatment. It's now just Niatex. We've been at it since 2007. We have now, the idea is giving systems the tools in order to get better. The idea for us is to reduce waiting times, reduce no-shows, increase admissions, and increase continuation between the first and fourth session, where we've gone beyond that now. The idea is now how do we improve paperwork? How do we improve communications? How do we enhance the provider, give the provider the tools for added value? Since the 2070, we have approximately 90 provider agencies and 25 units from the DBH IDS trained in Niatex tools and principles. The system has trained approximately 30 Niatex coaches, 25 agencies, and 5 are from the provider agencies. Telephonic Outreach. Saw a good idea, and by the way, ladies and gentlemen, I'm not above jumping on good ideas. I don't believe anything is new. I don't create anything. So the thing about it is that Jim McKay over at the University of Pennsylvania was doing a study around telephonic outreach. He was doing it in a clinical setting with master's level folks, and he was having some pretty good outcomes. So the light bulb went off. What about putting telephonic outreach in a managed care entity and have it staffed with people who are in recovery? Telephonic Outreach, TRIP. And TRIP is, Telephonic Recovery Initiative Project. First of all, we actually, brought in the folks from the University of Pennsylvania to actually, orient the staff to telephonic outreach. We then spread telephonic outreach, we put it in BHSI. That's the funding for the uninsured. We then moved telephonic outreach to ATR, and we'll talk a little bit about what ATR is, and we also put it in case management. The idea is that any place that we have in our system right now where the uninsured or underinsured are, we want to stay connected. Our feeling is that the longer we stay connected, the better the person stays engaged. And that's a bottom line issue, and I think we're seeing some results now come from that after the last 4 years. Office of a Journey of Hope, my personal pride. 6 years ago in Philadelphia, we had a we really had a chronic homeless crisis. And what we noticed was that a lot of the folks who were chronically homeless were drug and alcohol dependent. And in fact, met criteria for what we call long-term residential. Most of them met criteria for long-term, which is habilitation. But the thing about it is that they weren't going. The other piece was that they went, they didn't stay. And in actuality, what we found was that there was a war going on between quote unquote therapeutic communities and people who live out in the street. Give you an example. I live out in the street, I'm chronically homeless. I've been out in the street for 10, 20 years. I decide to come into treatment. The first thing you hit me with is a whole bunch of rules and regulations about what I can do and what I can't do. And then you tell me that if I don't follow these rules, you're going to kick me out. What do I say to you? Bye. What we did was we actually shut down initially 3 providers. We paid them to close down. We paid them to retrain themselves and their staffs to, number 1, lower the threshold for admission. Number 2, to be able to take a person back no matter how many times they came back and welcome them. And number 3, make it open-ended, which was another bloodletting with CBH, but I'll get into that later. The idea, though, is that we wanted to create, programs that address the needs of a chronically homeless culture. Now, as I said earlier, 6 years ago, nobody was coming to these programs. Since we installed these programs and opened them up, they've stayed full. You should also know that the end product for these programs is to get people independent housing. We have gotten almost several hundred people, 150 as of 2011, but we have now several hundred people, at least I think almost 300 people, who have transitioned into supported housing with case management, with telephonic outreach. And you see that, one of the things that we have is that we have a 53% success rate or completion rate, whereas nationally we're seeing about 39%. So, we're very proud of the Journey of Hope project. In fact, we actually have expanded it from the original 3 to now 7 agencies. And if we could, and if they would let me, I would actually have turned the whole system, the whole residential treatment system into this model. IRA. One of the things that we found early on when I first became director of the Office of Addiction Services was that there was a lot of conflict between the criminal justice system, the managed care system, and the persons who were in treatment. And the problem stemmed from the fact that people who did assessments behind the walls were oftentimes dismissed in terms of a person's need around treatment. They've been in jail for a year or maybe less. So why do they need to be in treatment? So that partially came from a number of folks who weren't really educated about addiction. And that people's addiction doesn't stop in their minds because they've been in jail. And in fact, one of the things that I have been, particularly attuned to is the issue of stress. And looking at stress in the community and how people cope with stress as being a very good indicator of about, success around addiction. And what we've looked at now is the fact that, one of the things was that we got three providers who were willing to work with us to take people directly out of incarceration from 2 to 4 weeks and do what we thought was a good comprehensive assessment. It has resulted in our initial findings, it has resulted in better placement of those folks. Not everybody got long-term residential, but the idea is that we got people into a level of care and a dosage of care that was more appropriate. And we see less recidivism in this population. ATR. Now, 4 years ago, we were able to get the grant, the Access to Recovery grant from the federal government. 4 years, we're averaging a little over 1 million syringes a year. Now, that says to me that if you say that, that the usual person who was shooting dope probably takes off about 1,000 times a year, 3 times a day, 365 days a year. So that means that we have at least 1,000 people out there that we're not seeing in treatment, but are probably shooting, actively shooting dope or heroin. So the issue for us is how fast can we get them engaged and into treatment? It's a slam dunk. Why weren't we doing this all along? Because the situation was that we had to make some choices about what we were going to fund and where we were going to fund it. But the reality is that we put folks from CBH and from BHSI on the largest syringe exchange site and on their day for exchanging, and said, okay, we're going to give people a get out of jail free card or a get into treatment free card. And if the person met criteria for residential or detox or whatever, they were going to get it. And so this program is up and running now, and we're seeing some interesting, in fact, I think we're going to end up having to figure out how to get more staff over there because the demand is now growing. So this is the good part for you guys. This is the data initiatives. This is where I want to try to get you guys intrigued in terms of looking at what we're doing. We are involved with the Community Epidemiology Work Group. We are one of 26 sites. Just so you know this, the funding for the CEWG has been cut. We don't know if they're going to continue. We would like to figure out a way, if they're not going to continue, that we continue this. So we're looking at how we can do that. We're also looking at data that we're using in terms of the Public Health Management Corporation in terms of their Southeastern Pennsylvania survey, and we're also doing something called the Philadelphia Profile. Just so you know, based upon the stats that have come out of the Philadelphia, Camden, Wilmington area, we used the 9.5% against the 1.5 million people in Philadelphia to estimate that we have about 145,000 people that need to be in treatment. This is a conservative estimate, and that's not really scientific, but this is our best guesstimate about the numbers of people that we have in Philadelphia. If you were to ask me, I would tell you that I would triple this number. And the reason why I would triple this number is because of what you're going to see coming up next, and that is the amount of folks that we're seeing who are getting arrested, the increase in the number of overdose deaths in the city of Philadelphia, and some of the increases around the presence of drugs in deaths. Just so you know, since 2004, this gives you an idea of the number of folks that have been served by both CBH and BHSI. And this gives you all the way through, through to 2013. And you see that pretty much we're, seeing about 37,271, which, by the way, which indicate that we are at a higher percentage than the national in terms of people who get into treatment. That, again, as I said before, is relative to the fact of who you're counting as needing to be in treatment. This is BHSI, this is the Behavioral Health Special Initiative. These are the uninsured or underinsured. We're using this as a proxy because I have better access to this data on demand. And you can pretty much see the services that we provided over the course of the year and the increase in intensive outpatient services and the fluctuation in the drug and alcohol residential. The fluctuation in drug and alcohol residential is largely due to our ability to get people on assistance. And that's the biggest issue for us right now. BHSI has been cut an average of $1 million a year for the last 5 years. And so we see ourselves as needing to now find a different way to maximize our dollars. That way right now is get them on CBH. And so we are moving, to get them on. And when you see the lowest numbers as far as residential is concerned, that's when we got to Expedited Plus Plus. The state was working with us in terms of actually, going back and doing retroactive enrollment. But since the GA cuts, the state has stopped doing that. So you see this steady increase back up again in terms of residential treatment is concerned. This is our CEWG data. Just so you know, again, we're a city of about 1.5 million. And this is very important here. This is, Philadelphia is in the red, has averaged almost 20 points higher than the national average of children who are living in poverty. That kind of stress is consistent with the high risk factors for people who are engaged in high risk behaviors, including drug use. We pretty much are much like the national average. However, we have a lot of opiates. And by the way, if you are a Flyers fan, if you are a Phillies fan, an Eagles fan, or a Sixers fan, you don't worry. Philadelphia can lay claim to the fact that for the last 25 years, we've had the best dope at the lowest prices in the country. Yeah, we get a big finger with a joint sticking up out of it, and go from there. Primary drug of choice, you pretty much see, is still, in terms of treatment, it's still alcohol, but now heroin has surpassed marijuana. Age profile, we're still seeing that for the most part, a lot of the drug use is going on between 18 and 34. We're also seeing that in terms of treatment admissions, there's still men, but in this area, when you see the heroin and the opiates, these numbers are growing for women. The race profile is, it's pretty much about the same as it has been, where African Americans are still predominant as far as alcohol, crack cocaine, and marijuana are concerned. Whites are pretty much predominant in terms of heroin and other opiates. These are the emergency visits in Philadelphia. And by the way, this is over a 6-month period. And this little sliver right here, almost 3,000 people between this July of 2012 and December of 2012 were for overdose poisoning. That's just for drugs. So the total number of you have 141,000 emergency responses. You have a good number that are drugs. In mortality cases, the drugs most frequently detected with the presence of drugs are, the top 10, 5 of the top 10 are opiates. The most commonly detected drug classes in terms of cases with the presence of drugs, bingo. Take a look at this. There's no drug that's had a faster climb and escalation in terms of being detected than prescription opiates. 10 most frequently detected drugs among alcohol or drug intoxication deaths. And these are drugs that are directly involved or identified in the death of someone. And again, out of the top 10, you see 5 are opiates. We're also taking a look at this in terms of, the fact that this has actually jumped on the scene over the last 4 years. Diphenhydramine. This is a very interesting stat. Of the 972 MEO cases of death with the presence of drugs, 497 were alcohol and drug intoxication deaths. But then take a look at this number. In terms of the average number of drugs found in a person, in terms of death, you have 7, almost 8 drugs that are being found. So we're not a monolithic society. We are very eclectic in terms of how we use drugs, and especially here in Philadelphia. Just so you know, because one of the ways we measure how we are doing as a system, we saw from 1970 through 2006 a steady increase in the presence of mortality or mortality with the presence of drugs. This is an outlier because this is the fentanyl epidemic in 2006. Since 2007, we've seen a downward trend, but these ups and downs are primarily due to opiates. Now, this may be a little bit difficult for you to see. This is our Philly profile. We've broken the city by zip code into demographics to take a look at each area of the city in terms of looking at where the biggest populations are. We've also taken a look at in terms of density to figure out what's going on in the city of Philadelphia. This is again the demographics, and the red lines that I drew on where we have the highest populations in the city. This is where treatment occurs in terms of zip codes. And this is also where you see, and it's not too unnatural to find that where you have the highest number of people, you have the highest number of folks that are being referred into treatment. Same thing, now this is, the same thing is true here. This is just a part of the city. But these are the retailers, by the way, in the city. I only listed one. The one in Center City has the most liquor licenses and whatnot. And by the way, that's going to change once, if they ever commercialize or make the alcohol industry, privatize. If they ever privatize it, this number is going to be is really going to explode, and I can tell that also not by this, but by the fact that the number of actual applications, has blown up. They said they can't even process them all. Okay, so you now have retailers. So now this is the crimes in these areas, and again, taking a look at all these areas that we highlighted in red, you see an interesting piece in terms of the numbers of people. Property crimes. Where I'm looking at here are the sales of narcotics. I'm also looking here at the EMS calls for overdose deaths. And I'm also looking at where in the city we're seeing most of our drug intoxication deaths by the use of opiates. And again, we're looking at, the same sections of the city where they have high populations. And if we were to go dig a little deeper into those demographics, you would also take a look at, the number of the house value, begin taking a look at the number of people who are working in these communities, and you begin to see that there are some indicators that for us to take a deeper look at these kinds of things. Now, Arthur talks about 4 building blocks, and I've sort of built them, from the top down, but I'm gonna go through this really quickly. 4 building blocks to our approach to care. And for us right now, it's, again, as I said before, vision and values and collaborations and the like. Under recovery supports, we're looking at recovery-oriented systems of care, people in recovery, families and communities, evidence-based practices, and I'll talk a little bit about EPIC in a second, alignment, coordination, integration of healthcare, and then at every level and modality of care, promoting advocates. Under physical and administrative policy, aligning concept with practice. We have to continue to move our providers and ourselves more towards a closer relationship between what we're saying and what we're doing. And I think that this is going to, be of interest to you guys. We need to have better ways, and Kathy Bolton has been doing a report card. We're doing, performance-based contracting, but we need to now have standards that we can clearly identify to the state, and I mean, not just to the state, but also to our providers. The reason being is this: we are living with a plethora of state regs that are minimal. And in fact, if you look at the state regs, it really doesn't have anything to do with outcomes or whether or not a person gets better or not. Just, are you doing these things? And the question is that are there certain things that are going on in providers? I'm gonna jump right down to this. For instance, do we have organizations that celebrate the people that they work with and celebrate their staffs? Do we have organizations that invest in the relationship? I mean, one of the things that Tom and I spoke about early on when he was doing that study over at the clinic that I was running was the fact that, the importance of the relationship that a person had was probably mattered more than anything in terms of being able to deliver quality care, building esteem, transformative and relationships. Is Roland behaving the same way 3 months from the date that he came in the door? Am I treating Roland the same way that 3 months later? Because if I am, then something is not happening here. There has to be something at every level that we can talk about that's transformative. And if I can't say to you that I'm treating you differently than the day I first met you, then there's something inherently bad, and I'm gonna say bad, at the risk of putting a value on something, about the way I'm relating to you. And then last but not least, is the organization building culture? Are they producing people who are making a difference? And that both in their staff and the people that they're working with. And most of all, are they serving people? And the reason why I'm saying serving as opposed to helping is because when you serve someone, the first thing you have to do is listen to them. And part of the issue that we have in our system is that we still don't listen to them or to each other in many cases. So now in the future, how am I doing for time, by the way? Am I okay with the time? Okay, well then we're okay. For the last 2 years, the Office of Addiction Services has been funding what I call recovery enhanced treatment. We have providers in our system that were getting, our program funded allocations, and by the way, we brought them in and asked them what they were getting it for, and they couldn't tell us because they were getting it for the last 30 years. And since that time, CBH has happened, BHSI has happened. There's no need for additional funding or for a separate pool of funding for the uninsured. You have a higher rates of payment from the managed care entity. So why are we paying you this money? And in fact, even though we got rid of the term program funding, we said we're going to try an experiment. We're seeing that recovery enhanced services bring added value to treatment. And so what we're saying to you is this: we want you 21 providers to now, we're going to pay you $5 every 15 minutes for telephonic outreach, $10 for every 15 minutes for peers, and $15 for every 15 minutes for recovery management. For want of a better term, could be case management. Now those 21 providers, we had about 8 that adopted this and ran with it. But believe it or not, we had providers that never called anybody, never hired a peer, and couldn't tell you today what recovery management is. And I hate to tell you this, guys, but we've notified a few of those providers that we're not going to be doing business with them. And to that end, you may see statues of Roland hung in effigy all along Market Street, and I wouldn't be surprised if City Council came after me. But the issue is this: is that we have to begin to change the conversation. And we're not going to be, there's no solution to the problem, by attacking with the same mistakes that created the problem. And so we're now going to do something differently. And we're moving now to talking to providers about, first of all, don't come to us asking for increases in this and increases in that. We want you to come to us and now talk about bringing a consortium to us. Figuring out a way that you can bring not only yourself, but also the other stakeholders in your community, and let's talk about putting together a package deal. Also, let's get away from this term fee for service. It's my belief that fee for service is going to go the way of the dinosaur, and we're going to try to find alternative payment arrangements. So our challenges. First of all, is aligning thinking by changing the stigma discussion. I think that one of the biggest hindrances that we have is that when we sit down to the table with city council people, legislators, the folks who fund different things, as far as our advocacy agencies, we still have underlying stigma that affects us in 3 basic areas. One, on the individual level, it impacts on worthiness. People, that's why we have 23 million people who need to be in treatment in this country, and we only see about 3 million. That's why we have, over 145,000 people in Philadelphia, and we're only able to see 37,000. Because we don't do a great job in terms of the messaging around us. On a public level, stigma impacts on the disparities in care. It's about rights. And stigma undermines the rights. That's why we have places in Philadelphia where we don't have a continuum of care, where we don't have a lot of service delivery. And if you were to go back and take a look at that grid, you would see that there are areas, especially those areas that are in red, that don't have enough services. Where in some cases you have places that have a plethora of services. Then the last area, in terms of the public side, stigma impacts on conflict. And that gets to the quality of care. It's okay to defund drug and alcohol. It's okay to marginally fund, the treatment for a disease. Whereas if you were talking about anything else, people would be outraged that you would undercut, the support for, disease management of a disease that, pretty much impacts on 23 million people. We're looking to, coordinate healthcare and wellness initiatives. No longer are we talking about just treatment. We're talking now about wellness. We're looking to integrate behavioral health care and bridging funding regulations. We're talking about integrating with physical health care. And the reason why I'm saying integrating, behavioral health care, we're still not there yet. In the city of Philadelphia, we still need to work on how well my office and the Office of Mental Health work together around regulations, around funding, and around technology. And then we have to, and again, this gets back to integrate the funding. We can do a much better job in the drug and alcohol world with the co-occurring community than the mental health folks can do with the co-occurring community. Why? Because in many cases, the co-occurring community are the folks that scare them half to death. And in actuality, we're seeing a good study that was done by Kathy Bolton showed that in a 4-year period, a 3.5-year period, excuse me, there were 2,311 people that recidivized into acute inpatient services between 4 and 9 times. Of that number, we saw that the people who went into 23-hour beds, which is purely a psych observation bed, you know, over 60% of them who tested for drugs were positive. In the most intense bed, the acute psych bed, over 40% that were tested positive. So the issue is this: if we had just saved one episode of care for each of that 2,311 people, we would have saved $18 million. Now, I don't know about you, but I personally would have liked to have been able to put that $18 million back into the infrastructure for drug and alcohol, expand the co-occurring capability of providers, enhance the staff, and actually raise the whole standard of care within the system. And I'm still at it, so we'll hopefully stay tuned on that one. So, recovery continues as wellness. We're adopting a public health perspective. We're looking at trying to reverse ESPRT. We're trying to convince Tom to get involved with Bill White, Arthur, and myself so that we can begin looking at long-term recovery checkups. And I've added to this, reverse engineer ESPRT. ESPRT shouldn't just be about a doc doing a screening for drug use and referring that person into treatment. It should also be the drug treatment program doing a screening for medical problems and referring that person into a doctor. And the reason for that is this. I'm sorry, it's a little bit too dark. We did a survey with the Philadelphia Public Health Care Corporation. And that survey was done 3 years ago for southeastern Pennsylvania. And the good news first. The good news is that we found in southeastern Pennsylvania over 359,000 people self-identified as being in recovery. In Philadelphia alone, we saw 128,300 self-identified as being in recovery. However, part of the problem is that we have differences in terms of personal assets. And whether you look at, let me go over here on this side, hopefully I'm sorry, guys, for blocking you, but for measures of personal assets, high school graduation, we're seeing that they're lower than the people who are not in recovery. And that means people who are the general population. College degrees, much lower. Full of part-time employment, much lower. Unemployment rate, much higher. Unable to work, higher. And again, all these negative areas that we are identified in as far as recovery is concerned. The same thing is true of health status. When you begin to see whether or not health is fair or poor, there's a much higher rate of people in recovery who say that their health is poor, or fair or poor. Asthma diagnosis is higher. Diabetes is higher. Physical, mental, and emotional disability is higher. High blood pressure is higher. And in fact, when you think about it, past year, ER visits are higher. So we're also seeing, in fact, the only area that we were lower is obesity. And I think our folks doing crack cocaine may be supporting that number. Also, in terms of healthcare screenings and recovery status, we're seeing that, did not seek care in the past year due to cost. We see all these, and again, this is mostly all due to cost in terms of did not get needed prescriptions due to cost, did not get dental care due to cost. Again, just showing up higher in all these different areas. Women getting mammograms, in the past year, lower percentage of men getting prostate exams. But we have, HIV testing, we're higher. So we get tested. Because testing, by the way, is where? It's in the programs. Last but not least, we've been working with Dr. Robert Carter from Columbia University around the idea of introducing a survey into our providers around the idea of race-based trauma. And especially with our folks who are coming out of incarceration, you know, how big is that an impact? As I said to you earlier, I have been very much consumed by the issue of stress and its relevance, you know, to addiction and not only people getting addicted, but people staying addicted. And how we don't do enough in our programs to address this issue with folks and their families. So that's where we are as far as our, you know, anything that, the new stuff that we're doing. And this is, again, a reminder about the recovery walk. Last year, 20,000. We want you to come and, you know, be involved and hopefully sponsor some research folks to come and be in a part of the, you know, the group on the 20th of September. Any questions?